Hi, I'm Dr. Marcus Marcet, and on behalf of the Medical Licentiate Society of Hong Kong, I'd like to welcome you to this encore presentation from Dr. Andrew Yip, also known as Yip Sir, which took place on the 24th of November, 2020. Dr. Yip covers his surgery review for the HKLME Clinical Examination. The session took place originally by Zoom. Thank you for your interest and support, and thanks Dr. Yip for allowing us to reproduce the content here.
Last month, I taught on the membership examinations. They told the candidates, the MO, they told me that there will not be clinical case, meaning that there won't be any patients. About 2 months ago, I examined on Hong Kong U term test, final year term test. Previously, they did it on a hospital patient basis. So you take the student around and choose the patients and ask him to examine the patients, and then we'll discuss the case, and then we'll give marks on. But then this 2 months ago, I did it on a final year student, and that it turns out that they don't have any patients. They come up with cases, a sort of a history-based cases. It will mean that the format changed quite tremendously, and that the requirement will be different. Say if in the past they give you a patient with basal cell carcinoma in the face, so you take the time 1 minute, 2 minutes, 3 minutes to examine the basal cell carcinoma, and then you sort of give a running commentary, and then you tell the candidate, you tell the examiner that what the mass is like, and then there will be an ulcer like, and all these things. The examiners will ask you, so what is this? So this is basal cell carcinoma. So you spent 3 minutes already. And then you may discuss a little bit on the treatment, and then the bell will ring, and then you can go. The format changed. And what I guess is, now if they're going to give you not clinical cases, it will be by picture. They give you a picture, I guess, okay? They give you a picture, so you don't have to examine. So the time will be shortened in terms of you saw the pictures, and then you tell the examiner, this is basal cell carcinoma. It takes you something like 30 seconds, and you make that diagnosis. Then you have 4.5 minutes to be questions. You need to know your textbook stuff very well. So they may be asking you, what are the risk factors for basal cell carcinoma? What are the characteristics of basal cell carcinomas? How many different types of basal cell carcinomas would there be? And so what will the treatment? In the past, if you say surgical excisions, okay, then you can go. But now, since this is more of a paper type of a clinical case, then they will list out all the different type of treatments. Then you may be asked out radiotherapy. What are the chemotherapeutic agents that you use for the basal cell carcinoma? You know what I mean. So if they're going to give you paper cases, then the knowledge that you be asked will be in great depth. Now, I'll give you another examples. For the case that I've went 2 months ago for the final year students for the term test, it's not the final MB, it's the term test before the final MB, right? So this is called specialty clerk. They give you they give the candidates a history. Actually, that would be a case of carcinoma stomach, gastric pain, and all this stuff. Okay. Now, so they are. So I will be asking the candidates. So what do you think this is? So this is this can be carcinoma stomach. This can be peptic ulcers. This can be cholecystitis, and so on. Right. Okay. So what would you do? So you do an upper endoscopy, and then you take biopsies and so on. So what will you see? Then you will see adenocarcinomas. So what are the staging things that you need to go through? So they'll give you CT scan. They give you CT scan, and it shows that there is mass there, and there are lymph nodes there, and so on. So, and after that, you'll be asked, so what will be the treatment? So you said operation, but then they will ask you, so what are the standard treatment for adenocarcinoma stomach? So you need to say resection of the stomach. How much? So more than half. Now these are all standard questions that were set on the paper. So these are set questions. So the next thing is, after your resection, so how would you make the bowel continuity? So you need to say a polyar gastrectomy, a polyar type of an anastomosis or Roux-en-Y, and so on. Now, the last thing is, so what are the prognostic factors that you can see from the pathology from the slides, from the histology slides. So actually, these are for final year students. It means the same for your licensing examinations candidates. So there will be 5 answers, and that is all put in a paper, and then you need to ask the student, and they need to come up with. So it will be very difficult. So I tell you what, the histology slide will be: would there be lymphovascular permeations? Would there be perineural invasions? Are there signet ring cells presence? And also poor differentiations. So you will ask in great depth on the knowledge of the subjects. So in the past, if you have given the patients with cancer of stomach, abdominal mass, so after examinations you present a case, and then you say, well, what do you think? Oh, there is an epigastric mass. So what do you think this is? This can be cancer of stomach. This can be cancer of transverse colon. This can be something from the pancreas, and so on. So how would you prove? How will you prove that this is cancer of stomach? So I would do an upper endoscopy. Ring, then you go. So if there is no clinical case, the problem is you will be asked in great depth on the subjects that you will encounter. You know the whole story. I think if there are clinical cases, okay, is good for you, because the examinations will sort of spend or waste some of the times, so that you will be asked less questions. But if you are having paper type of clinical case, then you will be asked in great details first. The other thing is you will be asked on cases that won't normally be seen in the clinical examinations. Like you will be presented with an X-ray of a dislocated shoulder. Ordinarily, you don't have this, okay? In the past, they won't give you a dislocated shoulders for examinations in the final MBA, okay? So the thing is, if you are given a an X-ray of a dislocated shoulders, then you will be examined in great details of dislocation of shoulders. Okay, is anterior dislocations. So what are the rotator cuffs like, and so on. So the thing is, you need to. So my sort of talk tonight will gear into paper type of cases. Don't worry, I will try to come up with some of the cases that you might encounter, and tell you some of the knowledge that you might, or maybe you still have time to read up. Okay, so now, but before I start on clinical cases, let me come back to one of the stations that I find most of the candidates did not very well. This is my experience. So that will be the one on history taking. Now you will be given a station on history taking. If you are going to take a history, please do the standard. What the standard? Come up with the systemic type of questions, like chief complaint, history of present illness. And the most important, please write it down, the past health, social history, family history, drug history, smoking and drinking, okay? Associated risk factors. It's because the history is set like this, okay? There will be 1 mark for each of these. So they will say that, okay, like in the case of cancer of breast, the history will be the mother has cancer of breast. So if you don't ask then family history, then you lost 1 mark. The patient herself will be diabetic. So diabetic, more likely to related to cancer or whatever, okay? So please do it systematically, okay? So ask the history, the chief complaint, but remember to give something like 30 seconds, ask about past health, social history, family history, drug history, okay? Traveling history, smoking and drinking, and associated risk factors. So there will be invariably, there will be 1 mark for each of these. If you don't ask, then you lose 6 marks or 5 marks already, okay? So then you take a relevant history, like if it is hematuria, ask relevant thing. But if it is hematuria, I can tell you that most likely the patient will be working with the dye industry, dye industry, okay? So it must be someone with working in the dye industry. The patient will be a heavy smoker, because heavy smoker will be heavily rated with cancer of bladder, okay? So if you don't ask this, then you would lose mark. Or the patients may have a recent history traveling to Egypt for vacations. That will be schistosomiasis. Okay, so these are things that you need to ask. So if you don't ask, then you lose all these marks altogether. Now this is about history taking. Now, if it is going to be history taking, it will be some things like right upper quadrant pain or epigastric pain. So your history will be, you are likely to differentiate whether you are dealing with a patient with cholecystitis or you are dealing with patients with ulcer disease. then the question will follow. Okay, so if you think this is cholecystitis, what are you going to do? You do an ultrasound. If you think this is peptic ulcerations, what will you do? You do an endoscopy. So these are the questions that follow. Okay, so rapid cotton pain, another case that the patient be a patient with severe rapid cotton pain, fever, jaundice. So this is cholangitis. Okay, so this is cholangitis. So what are you going to do? So you do an ultrasound. You need to do a liver function test. You need to do the prothrombin time and all these things. And that for that case, it turns out that it's a bit difficult because it turns out that it is liver abscesses. Okay, cholangitis with liver abscesses. So you need to do a CT scan better, right, in order to delineate the number of abscesses, and then on follow-up, then you need to follow up with the CT scan or the ultrasound. And that the most tricky thing is most don't know that if it is liver abscesses, then you need to give antibiotics for a prolonged course, something like 4 to 6 weeks. And what type of antibiotics will you use? And then what are the how long would you give the antibiotics? Case of cholangitis. Now, I remember another case would be the rapid cotton pain, which turns out to be cholecystitis. Ask you on Murphy signs and what other signs that you're looking for and so on, right? Okay, and so what will be the operative approach? And you say laparoscopic cholecystectomy and all this thing. Okay, this is about history taking. Okay, history taking. Then you take a history from the patients. Now, the history that if you are going to ask the patients, right? If there's really a patient there, please proceed as in if you are doing it in the ward, in the hospital. If there is a sort of an actor there, you need to approach the patients. Now, you don't shake hands these days, okay? You need to introduce yourself, tell the patients who you are. Introduce yourself is one mark. Tell the patients who you are is another mark. Explain to the patients what they're going to do. So you're going to take history from her is another mark. Okay, these are point by point. Now, if you really have an actor, right? We don't have patients. So maybe there's an actor, okay, on the mask. Okay, they can have a patient. They can have a sort of actor, right? So you need to go through the formalities. Okay, introduce yourself. Make sure that Now, the tricky part is if you don't introduce yourself, so there will be marks deducted. I mean, not detected. You will not be given that one mark for not introducing yourself. History taking. Please start properly. Introduce yourself. Well, you don't need hand hygiene because you're not going to examine the patient. Okay, tell him or her what you're going to do. Take a proper history. Remember to ask the relevant history, like past health and all this thing, right? Social history. And then you come up with a tentative diagnosis. Then you will be presenting this to the examiners, and then they will ask the relevant questions on what are the differential diagnoses, how are you going to investigate, and all these things. Okay, obviously, history taking would be, I've said, rapid cotton pain, that would be cholecystitis, cholangitis, fever, and all these things, hematuria, dysphagia, breast mass. Those are standard things. Or a sort of relevant cases that comes up with in the student examinations would be abdominal distension. What do you mean by abdominal distension? There are two types. First one is pyloric stenosis, repeated vomiting. So you need to ask the history on this. Okay, the other thing is they will obviously the subsequent thing will be asking you on differential diagnosis and all this thing. Now the other thing would be large bowel obstruction, because large bowel obstruction is a very good topic to ask from history from patients and to ask questions from the candidates. Okay, so what are the causes of large bowel obstructions? What are you going to do, and so on? If the obstruction persists, what are you going to do? What are the management? So you say conservative first, drip and suck, and all these things. So and then they may give you a CT scan showing that there's a tumor in the descending colon or somewhere. So this is very, very, very good cases. Okay, large bowel obstructions, pyloric stenosis. Okay. And acute pancreatitis. All right. The next thing that you may be sort of interested, it will be the station on the on procedures. Okay. Now on procedures, obviously those things like catheterizations, insertion of chest drain, central line, and all these things, and also suturing. Okay, suturing. You need to know about it. Now, if you are asked to do a procedures, obviously you don't have a real patients there, okay? So you will be given a somewhat, maybe a mannequin, okay? You still would need to tell examiners that I need to get a consent, I need to tell the patients what I'm going to do, or whatever, okay? So don't just start right away and categorize the patient or pour the drain, okay? So you're going to tell who you are and inform the patients what you're going to do and so on. Maybe in some of the cases, now if it's simple, then you don't need to get a consent, but then there may be stations on procedures that you may be asked on getting a consent from a patient, get a consent from patients, okay? Now, getting a consent from patients will be like there is the examiner is sitting there. You don't need, in the past, we would have an actor there, like, okay, there is a gentleman, 55-year-old, sitting there in the past, okay, the actor, okay, sitting there. He is going to have a hernia operations. Please get a consent from him. Okay, please get a consent from him. So this can be in the procedure station. Okay, please get a consent from him. So you need to do the same as introduce yourself, sort of identify your patients, make sure that you are talking to the right patients. Okay, and then you need to verify your patients on the diagnosis. Okay, so the ACTM would be educated or being told that if you are not going to mention on the diagnosis, then you'll be sort of coming up with a different problem. Okay, then you'll be embarrassed. Okay, so now get a consent for your level would be something like a phimosis, hernia, or even as simple as getting lumps and bumps, or excisions of a lipoma, and so on, right? Now, if you're going to get a consent, always think in terms of the diagnosis. Now, you introduce yourself, you make sure that you're talking to the right patients, confirm the diagnosis, and then you start talking to the patients to get a consent. Always think in terms of pre-op. Pre-op meaning the diagnosis, okay? Operations. So what will be operations like? What are the risks? What are the dangers? And post-op. Post-op will be more like what are the complications that you may see, and that how he can return to his daily life. Right, like can he take a shower? Can he go back to work? Is he going to get analgesics and so on? So things in terms of diagnosis, pre-op, operations, and post-op. Okay. Now, say if you are given a lady, her son is going to have phimosis, to have a circumcision, then it's as simple as getting a consent from the mother for the son to have a circumcision. Now, it turns out that this question come up. It turns out that the response, the answer are very disappointing. Because the candidates, they don't do it systematically. Okay, so for the mother, the most important thing is, can the son go back to school? Can he join the swimming class after the operation? Is it very painful? Is there problem with passing water? So these are the mother's concern, and you are going to explain to the mother, okay? And some of the candidates don't even know that for a pediatric case, the anesthesia for circumcision is general anesthesia. Some will say local anesthesia. Come on, I mean, for kids, there is no local anesthesia for operations like this. Okay, it's not major. Okay, but then it is painful. So despite the fact that you talk to the patients and said that you're going to buy toy for him and all these things, once you cut on the skin, it is painful. Then he'll kick on you and then you jump down the operation bed. Okay, so it has to be general anesthesia, and some of the candidates don't even know that it has to be done under general anesthesia and say that this is local anesthesia. So so that turns out to be a big problem, and you need to know from the parents' point of view what they need to know. Okay, so despite the fact that it is a simple operations like circumcisions, it turns out that the answer is very disappointing for the candidates. It's because they don't know how it's done under anesthesia, and the other thing is very few of them talk about the patients going back to school, how long, and so actually the other thing is there's no need to take off stitches. Okay, there's stitches, absorbable stitches. So it is a painful experience to take off stitches also, right? So you try to avoid that, and so you use absorbable stitches, okay? These are things that you may be asked. Now, that comes up to one of the procedure station. So you may be asked to suture a simple wound. Okay. Now, know what absorbable sutures and what are non-absorbable sutures. Okay, if it's skin, then you use non-absorbable sutures, which is nylon. Okay, then you need to know when to take off stitches. Okay, if it is head and neck, 7 days. If it is abdomen, 8 to 10 days. Okay, if it is from on the forelimbs, it will be 10 to 14 days. You need to know when to take off stitches. Okay, knows about the absorbable and non-absorbable stitches. Okay, you may be asked as simple as to suture a wound. Okay, the examiner is there to look at what type of sutures you pick up. Are you using the appropriate needles? Okay, so for normal small wound, you use 3O and 3O needles. Okay. Now the other thing is local anesthesia. Okay. Now, local anesthesia will be a very, very common topic. Okay, so you need to know lignocaine, 1%, 2%. What will be the normal limits for patients like 50 kilogram or 70 kilogram? Okay, so it will be 3 milligram per kilogram. Okay, now, but if there is adrenaline, it may come up to 7 milligram per kilogram. So you need to know the dosage, how much you can give, and what are the signs and symptoms of overdose. Okay, so I think this will be asked if you are given a procedure station with, to perform a local, perform a sort of a simple suturing or to excise a lipoma. Okay, so know about local anesthesia. Okay, the dosage, the overdoses. Another, I've just talked about consent. Knows a bit about consent for CT scan. Now you need to get a consent for CT scan these days in HA hospital. It's basically because of the contrast. Okay? So the contrast has a renal toxic effect. So you need to know about that, okay? Go home and read about the contrast, the iodinated contrast, what are the toxic effect and so on, all right? So you may need to, in allergy, okay? The allergy for contrast. So they have a very high allergy effect. So what are the use of prednisolone for those patients who have allergy history? Okay, you need to know about this. I've talked about suturing, about getting consent, CT scan, lignocaine, catheterizations. Okay, catheterization will be simple, but make sure that you would be injecting water into a balloon. Okay, and make sure that you choose the right size catheter. Okay, so the larger number is the bigger catheter. Okay, so normally it comes from something like 12 French to 24 French. Okay, 24 French will be the biggest catheter. So normally you only use it for operative cases. So you normally use only something like 16, 18, and make sure that you know that there will be 2 lumen catheters and 3 lumen catheters. 3 lumen catheters will be one for irrigation of bladder. So meaning that you can, in one of the lumen, pass water or normal saline into the bladder and then comes out back through the another channel. The one of the channel will be for inflating the balloon. Okay, so there will be 3 channel. But normally, if you don't irrigate the bladder, you use the 2 channel one. Okay, so you need to know that there will be 2 channel and 3 channels, and you also need to know that there will be silicone catheters. Okay, which is supposedly you can leave it for a longer while than a normal ordinary latex Foley catheter. Okay. Obviously, before you insert, you need to give lignocaine jelly to anesthetize the urethra and ease the pain of the catheterizations. Okay, make sure that you check on the production date. Make sure that it's not. Now, insertion of chest drain, CFP line. Okay, so these are things that you may be asked. Now, for that matters, insertion of chest drain. Then I come to a new sections, right? It will be on critical conditions. Now, you may be asked on critical stations. One of the stations will be on critical issues. Say patients with pneumothorax, okay, and pleural effusions. Then you may be asked a little bit on the insertions of chest drain. I've written here acute cases. Okay. Now, this will come up in either in the history taking cases, or they will give you a full case, like they give you a history 1 page with patients with perforated duodenalosis. Okay, and they will ask you. They don't obviously don't tell you that this is perforated duodenalosis. And they will give you history. There was sudden onset of severe pain. There will be gastrium. There will be pain over the right shoulders and or whatever. Okay, patients have had the pain on and off for something like 2 months, and all these things. So they will ask you, so what are the differential diagnosis? Then it will be perforated duodenalosis. What are the diagnosis? What is the diagnosis, and what are the differential diagnosis? You may say that it can be cholecystitis or whatever. Okay, so these are the acute case management. Then you'll be asked on a lot of questions. So how would you manage, and how would you treat, and what are the complications and all these things? So this is now history taking is one thing, is on one station. Management of acute cases now and then comes up. Okay, so like now, right now, okay, acute pancreatitis, perforated duodenalosis, cholecystitis, and cholangitis. Large bowel obstructions, mesenteric artery embolisms. They will give you a patient with sudden onset of abdominal pain, and that there will be severe acidosis because the small bowel is dead and so on, right? So they will give you a CT scan and shows you that the small bowel is all dilated, and they will give you history that the patient has atrial fibrillations and all these things. Okay, so mesenteric artery embolisms. And then the next one will be lower limb embolism. Okay, lower limb embolisms. Okay, now as an intern, if a patient comes in with severe lower limb pain, absence of pulse, then this is a critical emergency. Okay, it's your duty to identify it and then to inform the seniors. So I think this every now and then comes up. Now the next one will be post-operative DVT or pulmonary embolisms. Now, as house officer, you'll be called to see these cases in the middle of the night, sudden dyspnea after operations, and that with hypotension and all. Okay. The next one will be these type of cases won't come up in clinical stations, but now if it is paper cases, then it will come up rupture AAA, okay, rupture AAA. And the thing that will comes up also will be head injury. And say patients ride bicycle, bump head, and then loss of consciousness, and then comes in all these things, pupil, if electro pupil dilation, and so on, right? And that will be you need to know all the type of hematomas, subdural hematomas, and all these things. Okay, so now these are the critical cases, but I have still some more, right? Burn, okay, patients who has burned, say 30%. So how would you estimate the depth of the burn? What are the management, the fluid replacement, pain management, and all this thing? Okay. Now the another thing will be post-op fever. Patients have a laparoscopic cholecystectomy done. So on the next day they will fever and so on, right? So what are the probable causes? Obviously, the simplest thing will be atelectasis, okay, chest infections, but drip site infections, all these things will come up, okay. So you need to know what, how, and to go around. Need to know a bit of differential diagnosis. Now, one thing that comes through my mind this afternoon will be massive blood transfusions. They can give you easily a scenario of a patient, okay, of a patient, 60-year-old drives the car, had an accident, hit on the tummy, hemoperitoneum, hemothorax, comes in and massive blood transfusion, blood 10 pints of blood were given and so on. So what are the risks? What are the complications? Hypocalcemia, hypothermia, acidosis. So how would you prevent this? If there is 1 pint of blood being given, not of the same blood type. So this is wrong blood group. So what are you going to do? So what are the risks? What are the consequences? So these are very good cases, okay? Okay, so massive blood transfusion, post-op fever, okay, and these are, now knows a bit about TPN, right? It may comes up in the technical procedure station, okay? So you need to know about needs to know a bit about central line, how to deal with central line fever, take the catheter out for culture and all that thing, okay? Now, one thing I don't know whether it will be too difficult for you, but pain control, post-operative pain, say a patient with liver resections, okay, major operations, okay, liver resection, hepatocellular carcinoma, post-op with severe pain. So what are the different type of analgesics that you can give to the patients? Meaning starting the simplest paracetamol, which is not very useful, okay? Then you can use the opioid types of analgesics, and then what are the sort of side effect of opioid, being constipation and dizziness and all these things, okay? Nausea. And then you can give the NSAID. So what are the side effects of NSAIDs? And then you can use a pump for pain control, okay? That will be related to fentanyl and all this thing, okay? So need to know a bit about post-op pain control. Now, one very hot topic, I guess, is infection control. Okay? So knowing about this COVID-19 and lots of these, Canada, okay? The Canada, new type of Canada, okay? Infections that's coming up in hospital, okay? I think it started in PMH, okay? So new type, it comes up with a strange name. It doesn't affect the year, but then it has got Canada otitis or things like that, okay? Meaning that the first one who discovered it is from a year infection. But then I don't think it has something to do with the year, right? Okay. It doesn't preferentially affect the year, but I think it is because this Canada is sort of very resistant to antibiotic treatment, okay? All right, so MRSA, okay? So infection control. You need to know whereabouts when to isolate patients, and knows about now. You know, if you go to a hospital, you know that they dispose the thing for infection control. The bag that they dispose of things will comes in black, red, and yellow or green. I can't remember. So that means something. Okay. For black is for ordinary types. For red will be things that will have very high potential of spreading infection and so on. So even the type of things that you use for infection control. Okay. So now those are about the technique, the procedures. Now coming to the clinical stations. Now, I think this will be paper clinical station. I've previously taught you on the clinical examinations. I hope you can still remember if you are given the patients, okay? So how to examine the breast, you approach the patient and examine the breast, okay? Meaning that you start with observation, what is saying. But I guess most likely you won't be given a case, but then say for breast patients, say they may give you a picture of a patient with a sort of a huge breast malignancies, 10 centimeters ulcerative growth, and then it's just serve as a starting point. So what is diagnosis? So you say, okay, this is most likely to be malignancy of the breast carcinoma. So how are you going to prove this? What will be the assessment method? Okay, so and then they will now. The thing is now this time, if you are given me paper cases, then you need to know your textbook stuff very well, because they may ask you on the long list of risk factors for breast malignancies for the patients. Okay, family history, early menopause, use of oral contraceptive pills, whether there's any uterine problems, and all these things. Okay, so you may be asked on the long list of risk factors. Please recite to me the long list of risk factors. That may be the question put to you. Okay, so and they may ask you, so what are the triple assessment? What does it mean? Okay, so what are you? So how are you going to administer on these patients? So you say you need a mammogram. They can give you a mammogram film and say, okay, so this is the film for these patients. Can you comment on it? So that means they will be asking you on a lot of textbook stuff, okay? And the other thing is like, can you differentiate tethering from fixations? Okay, skin fixation is carcinoma invading into the skin. Tethering will be the malignancies is sort of eroding onto the ligament of Ashley Cooper. Okay, so they'll be asking you on things like this. So tethering will be dimpling so tethering will be dimple. Okay, fixation you can't roll, you can't pinch up the skin. Okay, so they may be asking you another thing. And so after your diagnosis, what do you do for these patients? And now they won't ask you on very tough questions like broad breast conservative therapy, what are the place of central lymph node, how this is done. Okay, these are all membership questions. But then they will ask you, so in these patients, what are the poor prognostic factors? This is a huge malignancies. It is eroded into the skin. There are lymph nodes. So these are things that they may ask you if you are not given real patients like cancer of breast. Now in the past it's examining patients, and the thing is, so what I've done by that time the bell rang already. Okay, so the thing is, if there is no real patients, then you will be asked a lot on the textbook stuff. Okay, so for breast malignancies, so these are the things that you may be asked. Okay, so say if they ask you, so how would it spread? Say you say that it spread to lymph node. So where the lymph node that it will be spread? Okay, it will be to the axilla, it will be to the internal mammary, it will be supraclavicular, infraclavicular, or to the opposite breast. Okay, so name me the different type of group lymph node group in the axilla. So so these are all textbook stuff. So you need to know the textbook very well. So these are the things that you may be put to you. Okay. So now breast. Now say now if it's abdomen. Now I think for abdomen, it's very difficult for them to give you an abdominal mass, right? It is very difficult to give you an abdominal mass. Now, but they can give you a colostomy, a parastomal hernia, a picture of a parastomal hernia. Now, parastomal hernia comes up as abdominal cases quite often, even for final MB, right? It gives you a case with a parastomal hernia, a colostomy, but then it turns out that this is a parastomal hernia. And then they will ask you, so what is this? And then the examinations. Okay, so there's not much in the way of examinations, but then that you just tell them that it is a parastomal hernia. But then the thing is, they may ask you, how would you differ? Now, if it's a paper case, then they'll ask you, how would you differentiate from an ileostomy? Oh, yeah, ileostomy is more likely to be a permanent, permanent. Colostomy may be okay, maybe temporary. Okay. Now the thing is, so what are the complications? Complications of say ileostomy or colostomy. So ileostomy would be that there will be fluid and urethral imbalance. Ileostomy. Okay. But then colostomy. What are the problems with colostomy? So these are all standard questions like gangrene, prolapse, obstruction, skin ulcerations near the edge, and then there will be peristomal hernia. So these are 5 points already, five answers, and then there will be five points already. So how will you manage this and so on, right? So if we're going to give you a case of abdomen, I think colostomy will come up. Okay. So now the other thing that will come up with, and that can spark off with a lot of discussion, will be simple: a huge rapid mass that will be hepatocellular carcinoma. Okay, it's easy. But then there's a lot of discussion on hepatocellular carcinoma. So how would you prove alpha fetoprotein? What's the half-life? Okay, so you do a CT scan. And how would you sort of proceed with further investigation? Like in the CT scan, you'll be looking for portal vein thrombosis, hepatic vein thrombosis, which means that your chance of operations will be limited. If it's bilateral, and then the chance is if on both lobes, that it means that the patients cannot be operated. So what are the treatment choice that is left? Okay, so all arterial embolization and all these things. Okay, so these are the things that you may be asked. Okay, I've just missed that. On one of the paper case that in the past would be a rupture paper case, critical case, tells you a 60-year-old man admitted with hypotension, rapid quadrant pain, history of hepatitis B, and that's the case of rupture hepatocellular carcinoma. Okay, I remember there's a case like this. Okay, so rupture hepatocellular carcinoma. So how would you make a diagnosis? What a treatment and so on. Okay, so hepatocellular carcinoma. Right now, coming back to abdomen. Now I've just said that it would be easy for something that you can see. It will be colostomy, ileostomy. If it is really something very easy for you, it will be a huge rapid quadrant mass, it means the hepatocellular carcinoma. But incidentally, please read up right lower quadrant mass. Right? Okay, if there's a huge there's a mass that on the right lower quadrant. So what are the differential tests? There will be something like I tell you very quickly. Okay, right lower quadrant mass. The commonest will be appendicular mass. Appendicular, not abscess, appendicular mass, inflammatory appendicular mass, carcinoma of cecum. Okay, carcinoma of cecum. On the right side colon, there can be congenital diverticulum. Okay, congenital diverticulum. So diverticulitis on the right side. Okay, diverticulitis. It can be psoas abscess. Psoas abscess. Okay, it can be a huge chunk of lymph node on the right side, mesentery or whatever, which is lymphoma. Okay, lymphoma. Or it can be a common iliac artery aneurysm. And also from the bone, it can be a chondrosarcoma. Okay, there are lots of differences. It can be also tuberculous infections of the ileum, Crohn's disease. Okay, so there are many differential diagnosis for right lower quadrant mass. It is a very common questions. Okay, even for the final examinations, if you have got long questions, how would you manage a patient 6-year-old with a low vital quadrant mass complaining of a bit of pain for 1 week? Okay, so knows a bit about the differential analysis, and then you know how to proceed on. Okay, so now abdomen. Now head and neck. Now it's easy for head and neck. Just give you a picture. A mass here, parotid. Mass here. Okay. If it's diffuse, then it is a diffuse goiter, Graves' disease. If it's a solitary thing, then it will be a nodule or multiple goiter. If it is high up here, then it's varicose cyst. So I think they can come up with pictures, clinical pictures for head and neck cases. Okay, now they can give you a picture of a basal cell carcinoma here. Okay, so you need to know a bit about this. Okay, the thing is, it's not that it's not difficult to identify the pathology, but then the questions that follow will be difficult. Okay, will be difficult. Now the thing is, if it is thyroid, then they will ask you. If it is a nodule, okay, then it's a 3 centimeters, 4 centimeters mass over here, all right, side. Even the examiners can tell you that it moves up on swelling. So what do you think this is? Then you say this is a nodule of the thyroid gland. But then they will ask you, so what is the pathology? What is it like? So it can be a simple nodule, it can be a malignant mass, a thyroid malignant mass, okay? It can be a cyst, it can be an adenoma. So there are lots of things that you can be asked on. So how are you going to make your diagnosis? You say, okay, you do a fine needle aspirations cytology. So if this comes back to the papillary carcinoma, what do you do? If it is come back to follicular carcinoma, what is the danger? You ask about bone pain and all this thing, okay? So what are the different types? So what do you refer the patient for? You refer the patient for an ultrasound and all this thing, okay? So lots of things. Varicose cyst, the same, very interesting. Okay, so what are the contents inside? Why do you need to excise the thing? Okay, because it is cosmetic, and there may be infections, and also there is a very small chance that it may have a papillary carcinoma inside. So how will you prove that this is varicose cyst? So you say the tongue tuck sign. Okay, so it may be difficult to translate. Okay. But these are easy questions that will come up for you. Okay, parotid gland, parotid tumor. Now the thing is, name me the 5 branches of the facial nerve if you're worried about the facial nerve. So we ask you what was the main thing that you worry about? You worry about the facial nerve. So what are the branches? You need to name the 5 branches: the temporal, subchromatic, and all this thing. So the other thing is, what is the pathology? Now, in the past, you were not asked on all this. So you say pleomorphic adenoma. So how common is it? Is it whereabout is it common? I mean, majority of the tumor will be in the parotid gland. Okay, but the more you are away from the parotid, the more chance that you will be malignant. Because if it is from a small parotid gland, then the chance of it is being malignant will be high. So you need to know a bit about the malignancy, the real carcinoma of the parotid gland, or the mucoepidermoid, acinic type, and all these things. Okay, you need to know a few names. Okay, but in the past you won't be asked on this because time is up. By the time you ask, you say that this is a parotid. How will you prove that this is a malignant tumor? So you say you do a fine needle aspiration cytology and all this thing. Okay. The thing is, you might be asked, are you interested to examine the oral cavity? Why do you want to examine the oral cavity? Whereabout is the exit of the parotid duct? All this thing. Okay, so these are interesting things, and that you may be asked. Okay, so you need to know more. So 捉題目而家 OK so neck mass NPC but all cavity malignancies. Okay, but then now you won't be given sort of pharyngeal pouch things like that. Okay, laryngeal seal or things. Okay, but you may be given a picture of an inflammatory mass over the lower part of the neck, tuberculous abscess. Tuberculous abscess. Okay, very interesting. You can be asked on a lot of questions. What is collar stub abscess? Collar stub, S-T-U-B. Okay, stub abscess. What does it mean? How would you treat? How would you prove that this is malignant? Okay. So these are all the things that you need to know about. Okay. Now, fibrosis, you need to talk about the cyst trunk operations. Okay. Now, then it comes to basal cell carcinoma. Okay. You may be asked on the characteristics of basal carcinomas. Okay, so why do you think this is basal cell carcinoma? What do you mean by rodent ulcer? What does the rodent ulcer means? Okay, so these are the things that that may be asked. Okay. Now, vascular case, it just gives you a foot. Okay, a foot darkened. Okay, with a few toes being gangrene. Now, in the past, you make a diagnosis of peripheral disease, that will be good enough. But then this time, if you have time, then they will be asking you on what are the risk factors? What are the predisposing factors? Smoking, high cholesterol, and what are the diseases that may be related? Myocardial infarct, stroke, transient ischemic attack. Then you may be asked on drug history. You may be asked on how to perform the Burger's test and what does a positive Burger test means. And then you'll be asked also on ankle brachial pressure index. So what is an index of 1 means, and also 0.5, what does it mean? So these are the things that a lot of questions that comes up, and you'll be shown an arteriogram. Okay, you will show an arteriogram, and you'll be discussing on where is the segment of the disease and so on. Okay, so you may not be given a patient, but then you may be given a pictures, just a simple picture. Okay, and then you may be asked, so what are the associated problems that you worry? What are associated histories? You need to ask about chest pain, shortness of breath, palpitations, and all these things. Okay, so these are very good questions. Shortness of breath, 1 mark. Chest pain, 1 mark. 1 mark. Palpitations. Okay, ankle edema. So these are the things that are relevant. But I think you need to work a little bit on the book stuff. Okay. Now a varicose vein. Now varicose vein is difficult. In terms of, it's too simple, right? It's too simple. But then I think the question may be, how would you differentiate from deep vein thrombosis? Okay. Now read up deep vein thrombosis. I think it's a very good thing. It will be very good questions to ask you. Deep vein thrombosis and pulmonary embolism. Okay. Now the other thing that may comes up will be arterial ulcers and diabetic ulcers. How will you differentiate two? Okay, so they give you pictures and ask you which one is which one, or what do you think that this one is this one? Okay, these are the things that may be asked. Okay, AA. Now they can give you a case, right? A case. Sudden severe abdominal pain, radiate to the back, and then hypotension. And then, they will ask you on a lot of etiology of AAA, what are the, if it hasn't ruptured, what are the, how would you diagnose it? Ultrasound, CT scan, anything less than more than 5 centimeters will be dangerous, and so on. Okay. And also, they can ask you a massive transfusion on this case, okay? So, and they will ask you on the complications, okay? So, early post-op complications will be cardiac, massive transfusions. late post-op complication will be on graft infections. That's the most scary one. Okay, so you need to know a bit about this. And like the same, if it is for total hip replacement, total knee replacement, they will be asking you on infections and so on, right? Now remember, okay, read up on dislocation of shoulders. Okay, now that comes. I come to the orthopedic. Hang on. I come to orthopedic. Okay, orthopedic. Now still it will be. Now they won't give you patients. They will give you pictures. Pictures, low back pain, sciatica. They give you a MRI. Okay, a plain X-ray. Okay, it can be okay. So OA knee or arthritis of knee. Wow, it's easy. Just a picture stuck up in the X-ray box. The knee is totally destroyed and decreased margins, lots of what they call subchondral cysts and so on. Okay. Now OA hip. Now, but if I'm going to examine this, I'd rather give you a case of avascular necrosis of hip. Because avascular necrosis of hip, you have a lot of questions, even on cause, risk factors, and also where else do you have avascular necrosis in the body? It will be in the sort of a number of places. Okay, at the femoral head is one. The wrist. What's that one called? I just slipped my mind. Okay, the one of the bone in the here. Okay, forget it. Okay, this will be after you have a now fracture. Okay, and that's about the one of the carpal bone. Okay, avascular necrosis, and then you be asked on total hip replacement. Not the details, but what are the risks? What are the complications that you need to tell the patients? Now, cervical myelopathy and ankylosing spondylitis, okay? And then you have dislocation of shoulders. It's a very common problem. It's very common. It's a hot question. Okay, dislocate shoulders. Okay. I've spoken about joint replacement, and then rheumatoid arthritis. They just show you a hand of rheumatoid arthritis, and ask you all the different signs for rheumatoid arthritis. So what are the treatment and so on. Okay, so I think for orthopedics, if they're not going to give you case, they're going to give you pictures, X-ray and pictures. Okay, of cases. Remember, simple as show you the knee of a young man, one with severe muscular atrophy on the quadriceps. So that will be a torn anterior cruciate ligament. Okay, but then the thing is that you won't have the chance of examinations. Okay, but then you need to know because they will be asking you on a lot of questions. Okay. Right, okay. So now remember to read up things like pleural effusions and pneumothorax. Now, pneumothorax is tension pneumothorax that you need to read up. Make sure that you know about all the signs of tension pneumothorax on the X-ray, okay? So the ears pushed to the other side and so on, right? Pleural effusions, exudate, transudate, okay? So I think I have, excuse me, okay. Okay, I think I have gone through most of the thing. Now remember infection control, okay? Read a bit about infection control. what are you going to do in the ward if you have patients with AIDS or MRSA? I've written here massive blood transfusion, small bowel fistula. Okay, if it's small bowel fistula, what will be the consequences? Because it's mostly because of the electrolyte disturbance and all these things, fluid imbalance and so on. Then you may need to resort to TPN. So how are you going to give the TPN? Some simple questions like, so what are the things that will be included in TPN? So it will be what and nitrogen, protein, carbohydrates, and also lipids. Okay, so I'm not so much as what you expected to be asked in the membership, but then simple question: how many liters of fluid are you going to give? How are you going to monitor the patients? You mean that you need to monitor the electrolyte, you want to monitor the weight, you need to monitor the whether there's any fever and so on. Okay, so these are very good questions for asking in the exam. Okay, so I think I have gone through most of the thing. I hope it's useful to you because I was thinking of a new format of examination. I'm guessing that this is going to be the new format that is given to you. Obviously, if they give you the old format, I hope you still remember the clinical examinations that I've taught you. Okay. So, the scaphoid bone, the scaphoid. Okay. Okay, there will be vascular bruises in the scaphoid. Okay, so any questions?
Thank you, Dr. Yip. I think Andy is having an IT issue, so I'm going to have to step in and help him. Very, very helpful tutorial for the past hour. So thank you, Dr. Yip, again for your contribution.
Yeah, my pleasure. Okay.
I'm sure everyone is very happy to have you here, and as a society, we're very, very happy to have you on board with us. Are there any questions for Dr. Yip from the audience? And feel free to either type in your questions in the chat box, or provided that you're already on the camera, feel free to unmute yourself and ask as well.
Hello.
Hello.
Hello. Thank you, Dr. Yip. I'm a really big fan of you. Thank you for your contribution again. Thanks. I have a question. Will the gout occur in the exam in the orthopedic clinical station? Because it's gout account to, because you mentioned RAOA and a bunch of the disease, but will goats be examined? Is that possible?
Now, it is possible. Now, it has been in the past been examined. Gout, you mean the gouty tophi, right?
Yes,
now,
yes,
they won't give you a patient with severe pain with gout, okay, like the one with the red hot big toe, okay? So it's very painful. So they won't give you a patient like this, but they will give you a patient with gouty tophi on the fingers, on the hand. So you see some of the patients with severe problems, with severe gout, they will have tophi all over the body, okay? But especially in the hand. So they will have a sort of deranged joints and so on. So it comes up. But then the thing is, but it will be difficult in terms of the questions that they're going to ask you. Now, you see, if in the past they give you a patient that you can discuss, they can ask you to spend a minute to examine, and then they can ask you to present the case to you. Then it will take another 30 seconds. But then if they're going to give you a picture, then you identify a gout, then the following question will be very difficult. You see, I'm all the time thinking about subjects that will have follow-up questions that will be asked in terms of the topics. Okay, so gout, yes, in the past, but in the present scenario, may be difficult to give you a case of gout, and because not much in the way of follow-up questions that they will ask. Okay.
Okay. Thank you. Okay. Thank you.
Hi, I'm Dr. Yip back on. I saw some questions on the chat box. So there were people asking whether they're going to be needing to practice physical examination skills then, if there are going to be like no real patient in the exam.
Now, now from what I've heard is now the first thing is for the upcoming membership examinations, that will be next month. Membership examinations, memberships of the College of Surgeons, okay? There will be no patients. So it will be sort of a paper board. Now, from what I've examined for the final year medical students, again, it will be paper board. They give you a sort of a long case, and then they will discuss on the management and so on for a long case, okay? So I guess the chance that you're going to have clinical patients will not be high, especially these few days. I mean, with the fourth wave of the COVID-19 coming up. So I think it will be more on a paper type, and that I guess you may be shown pictures of clinical cases.
Any other questions from? There are a few more in the chat boxes, and there are somebody asking whether there are any particular books that you would recommend for us to read.
And there are quite a number of books for the membership examinations, but I would think that it will be useful to you as well. They are simple books in terms of lots of clinical pictures, tell you how to examine and all this thing, right? So yes, there are, but I'm sorry, I can't remember the name of these books. You can ask some of the medical.
It's okay. We will share. Yeah, we will share the books
now,
that we.
The other thing is, I just read in one of the questions. Is there a stations of calling the MO for medical conditions? Now, for membership examinations, there is really a station whereby membership examinations whereby you would be asked to call the professors or the consultants on special issues, like you admitted a patient with rupture AAA. Then you need to call the consultants to come back. Then you need to tell him why he needs to come back, the condition of the patient, and so on. There is really a station. Or at the middle of the night, you need to call the radiologist to come back because you need to do an urgent CT scan because as the guy has got a bump in the head and he is unconscious. So you need to ask the consultant's radiologist to come back. And the script is usually like this: the consultant will be very unwilling to come back. So you need to convince him to come back. So there is really a station for membership. I don't know whether you have got the stations whereby you need to call the MO, say patients with lower quadrant pain, appendix, okay? So you need to tell him that the right lower quadrant pain and that he's got a fever, the white cell is high. So this is where the high chance that is acute meningitis, and there's a high chance that you need to operate. So in the meantime, what you're going to do is you say, oh, I'm going to book a CT scan to confirm whether this is really a CT scan, the appendix and so on. So they are really, I really don't know whether there is a station like this, but it is a kind of a stations that did occur with the membership examinations. I was thinking that the two universities will be borrowing heavily from the membership examinations in terms of the type of stations and type of questions that they will ask. Okay. Okay. Systemic approach. Yeah, always be systematic, right? Now, I've told you that if you're going to ask history, if you're going to meet with patients, always start with greeting patients, making yourself known, asking the patients whether are you dealing with the right patient and so on. So if you're going to examine, you're giving patients that you'll be examining, always start with inspections, spend a minute talking about whether the patient is pale, sadistic, and all this thing, okay? And then before you touch the patients, okay? Now, these are the standard stuff. So if you're going to answer questions, answer questions like this now, be personal. What does it mean by personal? Say, now, if you ask, how would you investigate this patient with a probable rupture abdominal aneurysm? Say if the question is supposed to you, don't just say CT scan. I prefer to have a CT scan of the abdomen for this patient. Use full sentence, okay? I would do something like this. So patients with grave disease, okay? So what would be your investigation? A thyroid function test is needed. This would include T4, T3, and TSH, and so on. Okay, make sure that you don't speak. What are the investigations for this patient with probable thyroid disease? T3, T4, maybe TSH. This will be very boring. Okay, so try to answer questions with a full sentence and be personal. I prefer to do this. Okay，我覺得應該做個咩？This will be very good. Okay.
Hi, that concludes Dr. Yip's presentation. For more content from the Medical Licentiate Society of Hong Kong, please subscribe to our channels. We wish you all the best in your exam efforts.